Welcome to All Things Public Health with Alvin Kapitako. On this show, we bring you expert interviews, discussions, and stories about public health. Join us as we explore public health topics that are of interest to you, our esteemed listener.
Welcome to the All Things Public Health podcast. Today I am talking to Rolf Hansen, who is the CEO of the Cancer Association of Namibia. He will talk to us about the increasing cases of cancer in Namibia, some of the projects of the Cancer Association and the work that they are doing throughout the country, and everything that you need to know about cancer. Thank you so much again, Rolf, for honoring my invitation. I really appreciate it.
Always a pleasure. Lovely when we can share some information, create awareness, and we can also advocate through change with this podcast.
The first question is, I just want you to sort of explain the purpose of the Cancer Association and the work that you do.
So the Cancer Association of Namibia was established in 1968 by Dr. Bernard Abraham May. He was a physician, a surgeon at Windhoek Central Hospital, and also a former mayor of the city of Windhoek. He had a great passion for oncology. It was a relatively new field expanding in South Africa, and there were no services available in Namibia. He reached out to the Cancer Association of South Africa and the Groote Schuur Hospital to bring by caravan once a year doctors to Windhoek Central Hospital, where Namibians, then Southwest Africans, could be treated. The challenge those years were that it was accessible only to the Caucasian or the white Southwest Africans because of the apartheid system and everything. Cancer has always been very expensive. And the goal of Dr. May was to have cancer treatment accessible for all. So from 1968, the Cancer Association of Southwest Africa was established and reported to South Africa. But then a decade later, in the late 70s, the Cancer Association of Southwest Africa became fully independent, and all funds raised in Namibia stayed to the benefit of Namibians. And the oncology program started very slowly at Windhoek Central Hospital. Actually, our name was changed from Cancer Association South Africa to Cancer Association Namibia. And the association's main objective is to create awareness and educate on cancer. That is what our mandate says. But over the years, we've transitioned as the need has expanded. It cannot only be awareness and education. There needs to be a screening component, a support, a care, and also stakeholder engagement component. And that is where we are today. We have evolved from a small organization to one that is closely linked up and partnering with the health ministry to build policy, to implement programs, to provide support to cancer patients. So we have various programs today that support patients from all walks of life. We are in the regions through either volunteers or our network in partnership with the Ministry of Health at primary healthcare level and at district level hospitals to provide support. And I think we have transitioned successfully from what we were in 1968 to, almost 60 years later, where we are today.
Thank you so much for sharing that, and also just thank you for the important work that you are doing, really. So cancer is on the increases, we all know, but what are the contributing factors to this? And if also you have statistics that you could share, that would be very helpful to just put it in context.
So the challenge with cancer is it is such an evolving disease because it's the disease of our cells, our building blocks. And because we change, our living conditions change, our ecosystem that we live in, the bubble that we live in change so dramatically the last decade especially, cancer it has been, and it will be an increased burden on society and in our communities. In the past, hereditary disease was the most prevalent. You inherited it by biological markers, DNA. But now lifestyle plays the biggest role in this disease. It is the water that we drink, the chemicals, the hormones. It is the food that we eat, the stabilizers, the preservatives, the food colorants. It is the hormones in the food. It is the chemicals. It is the chemicals in our environment. It is the frequencies in our ecosystems, electronics. All these things play a role. And obviously there is, like, for instance, human papilloma virus, HIV, that has a contributing factor when it comes to our immune systems, where cancers like cervical cancer or Kaposi sarcoma develops. So there are so many contributing factors. Obviously, the critical lifestyle factors is tobacco use, smoking, obesity, not exercising enough, poor diet, overconsumption of alcohol. These are all triggers that contribute to cells mutating in our body. And those mutated cells are called cancerous cells, and that's cancer. And the one thing that stands out for me is, as the world is moving into an ever aging population, we're getting older. This is where the immune system weakens and shuts down a bit. And this is where our bodies cannot fight cell mutations. And this is basically cancer. Now, in first world nations, you have an aging population, but you have pristine health systems that can treat and look after. But when you look at low and middle income countries, especially in the African context, you see that our systems are still suffering and struggling with just the basic care, access to basic medicine, access to basic surgery, not just cancer, but across the board.
Yeah.
This places an even greater burden on our health infrastructure across Africa and across low-income countries, shall I say. And the most of low-income countries, unfortunately, are African. And this is why it is so important that we advocate for policy reform, that we advocate for policy development, so that cancer, which is one of the top 3 disease burdens globally and is moving to the top burden, is addressed, that universal health care is implemented, that palliative care is implemented. Because if you have policies in place, earlier interventions in place, if you have universal health care, which means access to treatment timely, readily, and not financially crippling the community and the population, and you've got palliative care for all disease spectrum across, not just cancer, but entire disease continuum. If you have those in place, then the country's health systems need not collapse. And that is why using cancer as a model to help expand and develop the country's health ecosystem, it's so beneficial, so critical, because we can learn a lot from this disease.
Thank you so much for sharing that. What are the common cancers in Namibia, and what demographics of the population are at risk?
Skin cancer has and will always be a challenge globally, especially in Southern Africa, Namibia the same, but you have invasive skin cancer, so they are not life-threatening. So those would be your basal and squamous cell carcinomas. Those are your superficial cancers, but they have to be addressed. The life-threatening cancers in Namibia, breast cancer per number. Per incidence, we have prostate cancer as the top cancer and cervical cancer. So those 3, breast, cervical, and prostate cancer, are critical. Now, you've also asked me about number statistics and these sort of things. Percentage-wise, 54 54.6% to be correct, of all cancers diagnosed in Namibia are women being diagnosed with a form of cancer. So primarily breast, cervical, Kaposi sarcoma, lymphoma cancers. So women are very, very, very vulnerable at this stage. Men, we have seen that we have late diagnosis of prostate cancer. Therefore, we've also pushed for the urology program within the state, as well as prostate cancer screening. And now we have seen that more and more men are coming to the table because of the PSA program. It's prostate-specific antigen, so it's a blood test that is conducted. And prostate cancer is now taking the lead. One of the big challenges that we have in Namibia is that about 79% of breast cancer cases are advanced breast cancer or metastatic disease. This means that women are presenting too late, coming through the whole referral system too late, and then the prognosis is poor. And then we're actually treating and we're not winning. We're seeing stage 3 and 4 cancers of the breast, and then women die unnecessarily. If we can actually detect, diagnose, and start treatment earlier, we will have much better outcomes. And this is why we've invested so heavily in those top 3. Thereafter, like I said, Kaposi sarcoma is a huge challenge, but also because our HIV program in Namibia is so strong and has picked up momentum, we see less Kaposi sarcoma cases because that one is associated with immunodeficiency and primarily then HIV. Childhood cancers is a challenge. We see about 3,700 to now 4,200 on average with the new statistics. We have about 4,200 cancer cases reported annually, and this number is increasing at a rapid rate. GlobalCan, the international registry that we also report and work with, they have indicated that we're going to have one of the sharpest, according to statistics and data that we are going to have one of the sharpest inclines in cancers reported in Africa. That is right here in Namibia. Now, we see that childhood cancer is on the rise, but we also know that it is because, well, all cancers are on the rise, but it's also because we are seeing more campaigns, more screening campaigns, and rollout of decentralized services, that people are being detected earlier, people are being screened better, people are being referred faster. So higher numbers of cancer do not necessarily equate death or an avalanche. It means that the entire process is being done correctly, that we are screening timely, that people are coming through timely, that we are actually saving lives. Because the earlier we screen, we detect, we diagnose, and treatment starts at the treatment facilities. We work primarily with the state system, because they are the most vulnerable. Yeah, so we can actually save lives.
So you mentioned that women with breast cancer sometimes present late for treatment. What could be the reason why?
So the challenge is that there's been a lot of stigma surrounding cancer, I must say. I think for a very long time, people have always assumed and agreed that cancer is a white person's disease, that it's a woman's disease, it's an old person's disease. And people still have this fear that once you're diagnosed with cancer, it's a death sentence. So we need to work a lot on breaking the stigma. And yes, women see and they know the signs and symptoms. I've come to realize traveling through the country with a national outreach program. But we are also afraid, and we think that if we do not present and if we don't show the symptoms and we don't report it, that, maybe it will just go away. And that is the big challenge. We should speak and we should address and we should talk to the community at a literacy level that everyone understands. We should speak in the vernaculars, the mother tongues, so that we can empower our women out there in the communities. We have started the breast clinic program in February 2023, and we have now rolled it out with partnership of the Ministry of Health, obviously, at Windhoek Central Hospital, Swakopmund, Walfish Bay Hospital, Onanjokwe Hospital, Oshakati Intermediate. And the hope is that through these breast programs, we will actually be able to catch women into the referral and navigations pathway or system a way a lot faster, a way a lot earlier. But it's very often also that because communicable diseases, HIV, tuberculosis, malaria, got all the attention and funding, and it was urgent that we need to address this because it was killing the people, NCDs were left behind. So non-communicable diseases, our cancers, our cardiovascular diseases, diabetes, And now we need to do so much work to get the NCDs program up and running and going. There is a policy, the government, we all sat together, we developed the NCD policy. But, the thing is, we now need to train and we need to capacitate also our primary healthcare workers and community extension workers that there are other diseases that we need to give attention to as well. We need to empower them and capacitate them to understand and see the signs and symptoms. Breast cancer, prostate cancer, cervical cancer, yes, but also those general, if a patient presents with persistent bleeding or a wound that does not heal or swelling or a lump, that we know that this is not just an infection. We cannot just treat by giving a Panado. We actually need to refer this patient to regional or district level and get blood work done. So it's a long process, but I see that with the cervical cancer program and with the breast program that we have initiated now and rolling out nationally, that things are changing, that through talks such as this, through sharing and creating awareness, people are actually just saying, oh, you know what, this makes sense. I have this bump or a lump or a bruise or a growth or a consistent discharge that doesn't seem normal. Something isn't right. Let me present myself to a local clinic or doctor, or if the local nurse doesn't know what to do, you get in the car or the taxi or the bus and you go to the district hospital and you say, outpatients department, here I am. I need help.
Yeah.
So empowering Namibians is critical.
I feel like you also answered my next question, which was you have the monthly clinics where you screen women for breast and cervical cancer symptoms, right? At the association. So apart from Windhoek, where else do you have this?
So the National Cancer Outreach Program we established during 2015 to 2017, and this is where we travel around the country to each of the main hospitals and to the clinics where we present screening, where we do awareness and education, where we try to empower the local primary healthcare teams to do screening and to understand signs and symptoms. And this is to build capacity, but also to be out in the region to see and to understand. Now, this program put us on the road. When I led it myself, when I started it for the first 3 years, we were on the road for 16 weeks a year.
Wow.
I'm very fortunate that my team are now well equipped and able, and we've got partners that make the world a whole lot easier and the job a whole lot easier for us. But, in 2015, 2016, 2017, when I started this program, Sister Christy Kavatuna, who was our head of medicine at that stage, and we traveled away from our families for 16 weeks a year through the country, crisscrossed, and we started to build this network, referral pathways, engagement with the doctors and the hospitals. And this is important. We need to be out there. What has happened in the meantime now is these decentralized oncology units that we've established with the health ministry. And if you can start with cervical cancer, might as well start and do something with breast and prostate. And you can do a treatment locally, a chemo here or medicine or a blood work or a follow-up or that sort of thing. But you need to empower these community health workers, and you need to empower our colleagues out in the regions as well. This is what we're busy with currently, and this is the strategic objective of the Cancer Association henceforth, to build capacity and to push for policy development and policy change so that we can actually decentralize oncology services. There are certain of these services that will obviously never be available all through the country. Nuclear medicine and radiation, because that's very costly. But if we can have at least some hubs where our patients can present to for that treatment, and we have basic oncology services, medicine, then I think we will start to win this war on cancer in Namibia.
Earlier, you mentioned also that there is a screening for men for prostate cancer. Could you talk a little bit more on that?
So prostate cancer has always been the big challenge because your men are very cautious of the digital rectal examination. So that's with the hand, the finger. And what we have worked on since establishing the National Cancer Outreach Program, I traveled and I investigated, and this is where the mobile PSA, prostate-specific antigen test, became a reality in Namibia also. We partnered with our colleagues in Germany, and we asked, could there be a solution to circumventing the rectal examination, the manual rectal examination, because we are losing the battle to prostate cancer. Men are actually presenting way too late and then they die. So the rapid prostate-specific antigen PSA blood test we then brought to Namibia, and we had challenges with the calibration. Obviously, it's humid and it's cooler up north and in the northern hemisphere. In Namibia, we have a very dry and hot climate, so we had to look at repackaging and all these things. And now this program runs very efficiently. And then in the meantime, also the Ministry of Health brought into this concept as well, and PSA whole blood is now available at all health facilities countrywide as well. So it's merely men need to go once a year when they've reached the age of 45 plus and go and get this PSA blood test. So much more convenient and easier than women with a pap smear or a VIA or with a mammogram on the breast. And this has truly allowed the opportunity to fight prostate cancer in Namibia, because the same as with advanced breast cancer, we had advanced prostate cancer presenting all over the country. Now what we see all of a sudden is because of the PSA program, we see more men. A counter effect of that is the urology division within the health ministry is overwhelmed. But in the same vein and the same approach as with the breast clinic, we're going to push for the decentralization and capacity building of state urology services as well, so that these services are readily available nationwide. Right now, all urology are referred to Windhoek Central Hospital. And we all have a collective responsibility, to help our health professionals, to help the state system, so that we don't overwhelm them and it all collapses. But at least we are seeing that with the PSA testing program, the prostate cancer management is much better.
Recently, you launched the Palliative Care Namibia. Is it a center or a house? So what is the purpose of it, and who will benefit from it? And is there a cost as well? That is, like, if somebody were to take their patients, is it free? Is there a cost involved?
So when we have our National Cancer Outreach Program that is fully complementary, it's funded by the Bank Windhoek Cancer Apple Project. And this is for free. We go out and we can give these screenings for free. So when a Namibian patient is in need of oncology services, of cancer care, it is free of charge available. And this is the misconception that people think the Cancer Association or someone needs to pay for the medical treatment. The Dr. Abe Cancer Care Center was established through partnership of the Cancer Association and the Health Ministry at Windhoek Central Hospital. And every Namibian has access to cancer care in our country, and it's free. It's readily available. Now, There are many Namibians who want to have private care, and I very often, unfortunately, still see where, I should put it very delicately, but the white Namibian community feel they don't want to go to the state facilities, even though they're a state patient. And then we have a few challenges to explain to them that every Namibian has access to healthcare.
Yeah.
Every Namibian has access to oncology care. And this is something that we should be proud of and thankful for. Our health ministry is truly trying. But we cannot play the racism card and say, I don't want to go to a state facility, or I don't want to go and lie in Katatura or Windhoek Central Hospital in between black Namibians, for instance. And we get this. And I'm very frank when I speak about this with you. That is something that breaks my heart, because after all, we are all humans. And after all, if we are all state patients, then we must agree that this is it. If one is fortunate that you have private medical aid insurance, or you have the money to get private treatment, it's wonderful. Private treatment, private hospitals, obviously wonderful. But there is no such thing as there is no health services for oncology available in Namibia. There is. And our doctors are doing a sterling job. We have some of the most amazing doctors in our oncology unit. Dr. Zitzman, we all know for many years. Peggy and Vula. We are so blessed that we have all these amazing people. And Namibians can truly be thankful, but we must also just honor and respect that our teams are working under immense pressure. Resources are a challenge, but the teams are trying their best. But yes, to answer your question, screening services are available for all Namibians throughout the country, and treatment is also available for all Namibians throughout the country.
What can we as Namibians do individually and collectively to sort of fight cancer or to support the Cancer Association?
I think we should all work at breaking the stigma, all become acquainted with what is actually out there, what is the disease, what services are out there, and what the Cancer Association does and what the health ministry does. The very frustrating thing for us as an organization is when we ask, please people donate, people ask, where does the money go? And I give, and what do I get back? But they do not understand. They do not do the basic research to just see what programs we have, what support programs, what we actually do. They just complain about the state of healthcare in the country without actually realizing that as Cancer Association and Dr. A.B. May Cancer Care Center, the cancer team at the Ministry of Health, we are trying in our own way to make it better for our patients. And if we all stand together and we all say, let's support financially, let's make a donation, let's work together, I think it will be a whole lot better. If we acquaint ourselves with the risk factors, change our lifestyle behaviors, if we go out into the street in the afternoon with our family and take a walk, if we eat a bit healthier, if we consume less alcohol, if we talk as mothers to our daughters about HPV, human papilloma virus, HIV, family planning, and empower our girls, as opposed to shy away from mother and daughter talks. If fathers, we talk to our sons about HPV, about healthy lifestyle, healthy living. If we as husband and wife talk to each other about better lifestyle choices, better food choices, living conditions for our families, then we are starting to win the war on cancer. So collectively, we can all and must all do more to create a healthier ecosystem so that we are a healthier nation. I was actually shocked to read just yesterday that Namibia is one of the most obese countries in Africa. We all have our role to play. Obesity is a serious contributor to cardiovascular disease, heart disease, diabetes, hypertension, and cancer. And these are the 4 diseases that are killing people. So we as Namibians need to live healthier.
That is such a powerful message. And thank you so much for taking the time to talk to me about the cancer situation in Namibia.
It's a pleasure, Alvin. It's a pleasure.
And that was the CEO of the Cancer Association of Namibia, Rolf Hansen, talking to us about the work of the association. You too can get involved by supporting some of their projects, such as the Bengventuk Cancer Apple Project, Pink October, Sprayathon, and many others. You can call them on 061 237740, and the country code is +264. You could also visit their website at www.can.org.na. Thank you so much for taking the time to listen to this episode of the All Things Public Health podcast. Until the next one, bye-bye.
Thank you for listening to All Things Public Health with Alvin Kapitako. If you enjoyed this episode, please share it with others, post about it on social media, or leave a rating and review on Spotify, Podbean, and other podcast platforms. Also, follow us on social media at All Things Public Health Podcast to engage with us.